Welcome, colleagues. In the world of polytrauma, probably one of the most critical decisions we make is when to proceed with definitive fracture fixation. So today, we're going to dive deep into the modern, physiology-driven standard that guides this decision, what we call early appropriate care.
Okay, so here's our game plan. We're going to start by framing the core clinical dilemma. Then we'll take a look back at the historical approaches, early total care versus damage control orthopedics. From there, we'll define what early appropriate care actually is, break down its objective physiological markers, and finally, nail down why EAC has become our modern standard of care.
So let's start with the fundamental challenge, the one that every single one of us faces in those initial hours with a severely injured patient. It's this constant balancing act between getting mechanical stability and respecting the patient's physiological reality.
And this is the million-dollar question, isn't it? Do we go now or do we wait? Because the answer to this has massive consequences. It directly impacts morbidity, even mortality, and it really dictates the patient's entire hospital course and their final outcome. Now, to really appreciate where we are today with EAC, you have to understand where we've come from. Historically, our practice was guided by two completely opposing schools of thought. They really represent the two extremes of the timing spectrum. This table lays it out perfectly. On one side, you had early total care, ETC, which said, let's fix everything right away, to get the patient moving. On the complete other side, you had damage control orthopedics, or DCO, which prioritized stabilizing the patient's physiology first, often just with temporary fixation. Now, these approaches worked well for the very stable or the crashingly unstable patient, but they left this huge gray area for that borderline patient, the one who's sick but salvageable. And here's the clinical tension, the classic rock and a hard place scenario. If you pushed for ETC in a patient who wasn't fully resuscitated, you risk triggering that devastating second hit inflammatory cascade, which could lead to ARDS and multiple organ failure. But if you just defaulted to DCO, you were subjecting a lot of patients to prolonged bed rest and the not insignificant hit of a second major surgery down the line. So this exact dilemma, this gap between the two extremes, is what drove the development of our modern paradigm, early appropriate care. It was designed to give us a much more nuanced, individualized approach. And this is the absolute key. EAC represents a fundamental shift in our thinking. We stopped looking at the clock and started looking at the patient's physiology. The framework is built not around the question, how fast can we get to the OR, but rather, is this patient properly resuscitated and ready to tolerate this surgery? Okay, that all sounds great in theory, but how do we actually objectively determine that readiness? Well, the EAC protocol gives us a really clear, data-driven framework. It relies on specific lab values to guide our decision. This framework really rests on a triad of objective markers. First up is serum lactate. We're looking for a lactate below 4, or at the very least, a clear and convincing downward trend. This is our number one sign that global tissue hypoxia, shock, is starting to reverse. Second, we're looking for the correction of metabolic acidosis. We want to see an arterial pH of 7.25 or greater. This tells us that the patient's own buffering systems are starting to get back in control of the situation. And the third piece of this physiological puzzle is the base deficit. We're looking for an improvement to less than -6. This confirms that we've restored adequate cellular perfusion and oxygen delivery. So together, these three markers form our physiological litmus test. So when you see these three parameters start to normalize, what is that actually telling you? Well, it's objective proof that the patient is moving out of that acute shock state. It means the initial inflammatory storm is getting under control, and most importantly, it tells us that this patient now has the physiological reserve to handle the stress of surgery without us causing that dreaded second hit. All right, let's bring it all home and summarize exactly why this physiology-based approach has become the undisputed standard of care in modern trauma surgery. This quote really says it all. The whole philosophy isn't about being fast just for the sake of being fast. It's about being appropriate. It's about timing the surgery for that individual patient's specific condition. This allows us to safely give the benefits of early fixation to way more patients while protecting the most vulnerable ones from our own well-intentioned but potentially harmful interventions. So this leaves us with a fascinating question to think about. As our understanding of the whole immunoinflammatory response to trauma gets better and better, what's next? What will be the next generation of EAC markers? Could we be incorporating specific cytokines or other biomarkers to get an even more precise, personalized read on surgical timing? That's really the challenge for all of us to figure out in the years to come. Thank you.